So I believe assessments are the backbone of competency-based medical education, and they're essential for us to actually assess the resident's progress.
So with competency-based medical education, we're looking at assessing residents according to their level of independence. So for example, is the resident able to perform a specific task independently, or do they require supervision, and what level of supervision is this? And in this way, we can start to assess whether residents are indeed competent and whether they're ready for independent practice.
Instead of just getting a single ITER, having kind of a feedback on individual skills, it's going to allow the resident to really critically evaluate what they've done, how they're doing, and how they can go about improving specific aspects of their kind of current abilities and competence. So I think it's going to be very beneficial.
The part that I like the most in CBME is the fact that they came with this idea of entrustable professional activities, the activities that form the core of your profession. And for me, it's so much easier for the clinician teacher to relate to these core activities in your profession instead of relating to abstract concepts such as collaboration, communication.
Now we really need to understand both within a moment, are you meeting the landmarks of this learning experience in a timely fashion? To how do you look on your time course against the average?
It makes very easy as well for you to assess competency when you base your assessment on entrustment anchors. What does that mean? Was the trainee able to perform the task independently, or did the trainee need some help performing the task? The trainee maybe was even able to initiate the task because he was not ready for that. When you relate to the amount on how much of the responsibility you can transfer to your trainee, it makes much easier to make such an assessment.
And the big change is that we're using entrustment-based anchors. And by that, I mean that we're actually assessing the resident in terms of the competence to be able to perform something independently. So it takes away a lot of the ambiguity of what is poor and what is excellent and what is good, and it kind of transforms it into, do we think they're ready to do this on their own, or did they need a little bit more help because I needed to be there, or I actually needed to do it because they weren't able to do it. And so it really is a very natural way, I think, for many faculty to think about competence.
This has allowed the residents to have a more concrete idea of what those expectations are of them, and as well as help the faculty be able to actually assess the resident. Because I think in the past we were using more generic terms for resident assessment and outcomes. In choosing more generic outcomes, we were having the faculty assess what they perceive residents' abilities should be for this specified level of training. So I think having more specific concrete anchors has definitely helped the residents as well as the faculty understand how to grade the residents' competencies.
More structure to the objectives that each level of resident should be completing, and essentially based on that, it will allow for more personalized feedback and also identify more specific areas of weakness that can be worked on.
In terms of starting to do these assessments, the first thing is actually observing people more frequently. There's this quote that I really like where they say that if we taught medicine, or if we taught music the way that we teach medicine, we would have somebody go play in a room and then come out and tell us how it sounded, which is very much what we're doing in medicine. We're having people go in, perform an encounter, we never witness it ourselves, and then we're asking them to kind of reiterate. So I think the first step is observing more.
I think feedback is something that's really beneficial for a resident, but it's something that we really gloss over, especially as we advance in residency. You did well, you did fine, you're on track, but getting that concrete feedback is really difficult.
So ideally in the future, this feedback will be more, I guess, captured, and we'll be able to feed that forward to either the program director or the competency committee and allow them to help the trainee to ensure that that learning need is met. And that's really the goal of our feedback, is changing it to something that is a little bit more rigorous and we can turn into a learning concept for the trainee.
In the current system is a resident who is struggling. There are many reasons why a faculty member may be reluctant to give that feedback to the resident, right? In some cases, the faculty member may say, well, there's nothing in it for me, right? This resident is going to be on to somebody else later. They may fear the fact that the resident is going to turn around and criticize them as a teacher. But there are a lot of reasons why a resident right now does not receive the feedback they need to receive to make them be a better resident or perform better later. The current system to CBD is actually going to force that evaluation to happen, right? The Royal College has already developed a much larger set of tools that are going to help our faculty members both teach and evaluate in all of the CanMed's roles. And programs are going to be able to pick and choose whether they want to use those tools or different tools, as we're moving into an era where residents are going to get much more timely, hopefully face-to-face, honest feedback about their performance, both good and less good, that's going to help them be better at their job tomorrow.
I think now that we're watching residents a lot more closely, we're able to perceive the residents who are not maintaining these abilities and are able to focus our efforts and individualize their learning plans a lot earlier than leaving it till the final year.
People may be aware, we certainly have, through very enthusiastic clinicians, come up with a couple of assessment stratagems that have been very successful locally.
For us in otolaryngology head and neck surgery, this has meant a new system of evaluation. So what we've done is we've increased the daily evaluations that are being done. So we've introduced a form of a daily encounter card in the clinic environment. We've introduced a no-score use, so an evaluation of surgical procedures in the operating room. And we ask residents to have 7 or 8 of those completed a month. So for us, what it's meant is more frequent assessments, more frequent measures, which really inform the end of rotation ITER to be a much more powerful learning experience for the residents.
One way that we're doing that in our program is the use of the CCAT learning tool. So it's a way that we provide our daily assessments. Ways in which we've changed it to encompass more CBME related outcomes is to focus more on residents' independence. So instead of the failure to progress, meets expectations, above expectations, we changed our behavior scale to be a more solid anchor, such as was able to complete the task independently, required close supervision, or required the staff to do the entire procedure.
Some projects that we're currently working on is we're developing the electronic O-score platform with the divisions of urology and orthopedic surgery, and we're trying to roll it across the Department of Surgery, and basically it's going to allow for increased efficiency and efficacy of sending out assessment tools after a specific either OR or clinical encounter. And by using the electronic platform, it'll feed back data that can be used to sort of observe the learning curve across time.
We want to make tools for the faculty that are the way you think, that are feasible, meaning that they're short, they hit the mark, they hit the point, and they're easy for you to integrate into your daily routine.
In pathology, we are trying to implement some new assessment tools that address competency-based medical education. We have some entrustment-based workplace assessment tools like the O-score that has been developed in the surgery department here at the University of Ottawa that we have adapted, and we will start to use it as part of our assessment program in the pathology department. Another thing that we have done is to create the field notes so we can give immediate feedback to the resident, and we do not have to wait until the end of the month, the end of the rotation, to fill out the ITER.
Overall, I think right now we're doing a good job. We just need to figure out how to chip away at the things that we are doing and make them fit into a more transparent assessment process. I think the difficult thing right now is really trying to fragment everything that we're doing and just put it down on paper. There's a lot of stuff that happens in the background that people intuitively do. There's a lot of implied assessment, implied feedback that happens. We just need to be a lot more vocal about the way that we're doing that and to really commit to it.